Don and I are really pleased to talk about a subject that is truly near and dear to our hearts, and that is translating evidence into action. We're going to talk about how to bridge that gap between evidence and practice, and we call this implementation science. Or, as when I explained it to my 20-something-year-old son some time ago, he said, "Oh, I get it. It's the science of getting stuff done." I'm with that. That's what it is, the science of getting stuff done. So think of our talk today as Implementation Science 101, kind of an introduction. But for people who are interested in more, Don and I teach a class and we welcome auditors. Let me start with a case. This is semi-traditional in grand rounds. This is a real patient. This is a patient I saw years ago. I still remember his face, but he could be a stand-in for so many patients that I've seen, and I'm sure for a lot of yours, who somehow fell through the cracks. So Mr. E, he was a 67-year-old guy, diabetes, hypertension, congestive heart failure, presents to the emergency room with worsening shortness of breath, fatigue, orthopnea for the last week. 2 weeks ago, he was discharged for a CHF exacerbation. They prescribed him the usual meds, but at suboptimal dose. He didn't take them consistently, mostly due to the cost. He had a follow-up visit with a primary care doctor. It was a televisit, and it focused more on diabetes than congestive heart failure. He lives alone. He's in a small apartment. His family's in Mexico, doesn't have a car. You can see his vitals there. He had crackles, edema, elevated BNP, and effusions. You will not be surprised to hear that he was readmitted, and it wasn't even the first time that he had been readmitted. So what happened here? It's not a puzzling clinical case. There's no diagnostic dilemma. And there's a lot of research and strong randomized control trial support for the care he should have gotten, the medications he should have been prescribed. In fact, he was prescribed them, but just at inadequate doses, and for close follow-up with daily weights, but he didn't get that. So why was best practice not implemented? You know, there's less research on that. But surely social determinants of health played a role. He came from a disadvantaged background, and I'm sure that made it harder for him to take and up-titrate his meds. And no doubt that these social determinants are important, but I worry about focusing exclusively on them. Because if we say it's society's fault, or even the fault of the patient's situation in society, it's not enough. It lets us, the healthcare system, off the hook. What can we do to ensure best practice? Could the discharging team have done something to make sure this patient got optimal medical therapy? How come the primary care doctor focused on his diabetes rather than congestive heart failure? What could we have done differently? To answer these kind of questions, we can use the same scientific methods that produce the evidence for the medications or for the daily weights. We can use rigorous studies to figure out how to ensure best practice. And the field of study that engages these questions is called implementation science. But first, let me go beyond Mr. E's case to convince you that implementation science is truly needed. In other words, let's ask, what's the evidence for how well or how effectively we already implement best practice? I have several answers for you. First, we are slow. I am sure a lot of people have seen this slide. And it kind of views the translation of evidence into practice as a pipeline or a funnel. The government sets priorities for what sort of basic health research will be funded. And then a lot of people like me apply. Some are successful. They find out something new about how to treat heart failure or how to deliver better care. They publish their work, gets into guidelines, and then the people who are actually doing it read the guidelines and change their practice. Seems straightforward. What's strange, though, is how long it takes. Studies of drug development would lead you to believe that it takes 17 years to result in a significant change in practice. And although it's not usually mentioned when you see this slide, this odyssey is not just for drugs. It's for any kind of innovation in biomedical informatics, organizational structures, say, for example, case management of heart failure after discharge. Takes a long time. Not only are we slow, but we lose information along the way. If it's a pipe, the pipe is leaky. Estimates vary, but at each stage, the leakage rate is quite substantial. This is another study, and it confirms the delay that I was just talking about is measured in decades, and it estimates that only 14% of findings make it to the end of the pipe. Not only are we slow, not only do we lose information, but we fall short. Here's an example of empirical work I did a while back on just the far end of the pipeline that connects guidelines to practice. This was a national study, widely accepted medical practice, bread and butter stuff like beta blockers for, like as we were just talking about in Mr. E's case. And we found that overall patients were only getting about half of recommended care. This is nationally representative review of medical records. So the leakage rate in that last section of the pipe is around half, 50%. Just for a split second, let's dwell on how bad that is. Imagine every time you bought a smartphone, there was a 50-50 shot it wouldn't work properly. Quality improvement types used to talk a lot about Six Sigma as the goal, meaning the chance of errors is 1 in a million. We're not at 1 in a million like computer chip manufacturers. We're at 1 in 2. So the question is why, and how can we improve it? And implementation science has at least part of that answer. Okay, you're thinking, we've had a lot of time since you saw Mr. E all those years ago. We must have got better. Well, Risha, Gidwani, and I are in the process of repeating a subset of that same study using current data and current EMR, and the number we came up with was weirdly similar, 55%. And don't take my word for it. Here's a 10-year chart of primary care national quality indicators over a decade. And the answer is we still fall short, around 50-50. About a third of these indicators are up, a third down, a third the same. Not only are we slow, not only do we lose information, not only do we fall short, we are inefficient about it. The National Academy of Medicine estimates that 30% of healthcare spending yields no benefit at all. Here you can see on the next slide, data from Will Schrank divvying up the various implementation failures that cause those inefficiencies. Failures of care delivery, failures of coordination, or overtreatment with low-value care. These add up, according to the study, to $200 to $340 billion every year in the United States. You know, even for the healthcare system, $200 to $340 billion, that's a lot of money that could have been spent more wisely. All right, hopefully I've convinced you that there is a gap to bridge. So let's turn to how people have tried to bridge it. Here's the OG NIH traditional theory of translational research. It took that pipeline idea that I was talking about to heart. First, we discover something important about congestive heart failure, say, and then that tells us how to develop new tests or interventions, BNP or GLPs, drugs. That process is called T1 translation, or what's called T1 translation by the NIH. Now, if we work to incorporate those new things, those new tests or interventions into policies, that's called T2 translation. And later, the NIH extended it to T3 or T4 for later sections of the pipe. But my point on this slide is that I think a big part of the problem is the one-way arrow, those red arrows that are inherent in any pipeline model. You put something in the beginning and it diffuses out somehow naturally to the end of the pipe. Researchers and policymakers discover something new, but then they translate it into telling clinicians, patients what to do. So therein lies the issue. People don't like being told what to do, and maybe if it was more of a dialogue or a two-way street, not so much if it would leak out. And studies of innovation, both inside and outside of healthcare, support that idea with quite a bit of evidence. Think biodesign. Next slide. So the NIH tried to incorporate this dialogue idea really taken from community-based participatory research. And the pipeline has become more of a web or a circle. So basic discovery research into the causes of heart failure informs clinical research, but also vice versa. Same thing for the whole translational spectrum, from preclinical research to public health. The key is the process is not linear or unidirectional. Each stage builds on and informs the other. And the NIH has incorporated this model into their large infrastructural grants, like the CTSA, led by our Senior Associate Dean, Ruth O'Hara, and the internal K program that's part of it that I lead. The essential insight of dissemination and implementation science is this: you can use the same scientific methods that produce the studies inside those 5 little circles to study the lines that connect them. Science can help us understand not only what to implement, but how to implement and disseminate effective interventions. Another important thing to realize from this slide is that translational science and implementation science specifically is essentially a team sport, team science. For translational science to work, it has to be collaborative to take advantage of that dialogue and those two-way streets. And thank you to the team science leaders in the department for sponsoring this talk. And if you find yourself writing a grant in one of those 5 little circles, and you need to write an aim about one of the lines, we implementation scientists in primary care and population health are very happy to help you, as Donna will get to more at the end of the talk. You may be wondering, this sounds an awful lot like quality improvement, and no doubt there are similarities, but there is an important difference. Think for a minute about the spectrum of the translational sciences, from basic science to implementation science, until you get to the line that divides them from quality improvement. All of them are trying to validate theories and draw generalizable lessons. But by the time you get to quality improvement, that's no longer the case. To call something QI, you have to explicitly say that your primary intent is to improve the care of the patients right in front of you, to help decision makers in your system right here and now. So while many of the methods are similar, even if implementation science tends to be more in depth or more rigorous, it's the generalizable intent that is the bright line that divides implementation science from QI. So these are the kind of generalizable questions that implementation science asks. Questions about acceptability. Will doctors be willing to use it? Cost effectiveness. Is it worth it, say, for the hospital to buy this new thing? Appropriateness. Is this the right intervention for this context? Reach. How many are exposed? And benefit. Intensity. What's the expected strength of this intervention in the real world, not in randomized controlled trials? Satisfaction. Do stakeholders like it? To what degree? Sustainability, can it be continued over time? And more from Donna on this in just a minute. But in the meantime, let me turn from the theory to a brief history of implementation science. In a way, implementation science is as old as modern science itself. Take Louis Pasteur. He was interested in disproving the idea of spontaneous generation, replacing it with our now familiar germ theory of disease. But it wasn't just about pursuit of truth for him. He invented pasteurization and rabies vaccination, and he helped make sure that lots of people were using it. He said, to that person who devotes his life to science, nothing can give more happiness than increasing the number of discoveries. But his cup of joy is full when the results of his studies immediately find practical applications. So maybe implementation science isn't so new after all. In any case, I agree with him that it is not a choice between science and application, between research and implementation. We can strive for both. We can both work to develop better drugs for Mr. E and also study how best to get those drugs for him. One of the early implementation science pioneers was Everett Rogers, who wrote this book, Diffusion of Innovations, like 50 years ago. Did some very influential empirical work. Here's a graph about his work on the relative frequency of decision maker types for spreading innovations. The now commonplace term that's really hard not to have heard of here in Silicon Valley, the early adopter, that's him. Early adopters take innovations and test them for the mainstream, so the rest of us value their opinions in deciding whether to adopt it. The idea of the tipping point, which is popularized by a book of the same name, Malcolm Gladwell, is also his. It's the inflection point on the yellow curve, where enough people have adopted the new drug or the innovation, so it becomes easier for everybody else. Anybody know this guy from his heroic portrait in the Wall Street Journal? This is Peter Pronovost. He is truly the hero of Atul Gawande's book, The Checklist Manifesto, back in 2010, I think. Here is his implementation strategy for reducing catheter-associated infections. Really, this is it. 5 simple things to check off every time. Wash your hands. Use sterile technique. Don't place the catheter in the groin unless you need to. Clean the insertion site. Remove it when you can. Simple stuff, right? Except people weren't doing them consistently. Here's the adherence rate for 4 similar processes. It varied from 20 to 70% at baseline. So just by getting doctors and nurses to use this checklist, much like a pre-flight checklist for pilots, he was able to change that. This is a table from his much-cited New England Journal article showing a big decrease in the incidence of catheter-associated infections, 40% or so. And it was sustained for 18 months and 100 plus ICUs just by using that simple implementation strategy. Fast forwarding, in a lot of ways, the pandemic was just one huge implementation challenge. Pretty quickly, we found new, better ways to test for, to treat, to prevent COVID. We just had trouble getting doctors and patients to use them. What we needed was to better take into account other factors, not just the effectiveness of those testing and treating modalities. Things like how to make vaccines seem safe to people who distrust the scientific establishment, or how to reduce barriers to testing or treatment through community outreach. There was an enormous amount of work testing different implementation strategies during the pandemic, and institutions that heeded those lessons got better results. And anytime there's a new or effective technology, the earlier we study the implementation challenges, the better those results are going to be. I imagine there probably aren't anybody in this audience, there isn't anybody in this audience who disagrees that AI has the potential to transform medical care. One of those ways is its amazing ability to predict outcomes. Really, the prediction problem doesn't even seem to be the hard part, right? It's the software is getting that good. For example, there's a great algorithm that can serve as an early warning signal for clinical deterioration. It can do that in real time using Epic EMR data. Probably a lot of people in the audience have even used it. Instead, the hard part is not the prediction, but what are you going to do with that prediction? As Ron Lee here at Stanford has shown with his colleagues, for the prediction to actually help the team and the patient, you have to build new collaborative AI workflows. So integrating AI into medical care is the next big implementation challenge. Here's another example, the same thing. This is ongoing work by Rob Gallo, Ethan Go, and Jonathan Chen here at Stanford. They asked doctors to generate a differential diagnosis from clinical vignettes, either with or without ChatGPT help. We know that ChatGPT is really good, actually, at generating a differential diagnosis. Weirdly, using ChatGPT did not increase the completeness of their differential. Even more weirdly, ChatGPT did better all by itself. How could that be? When they delved deeper, they found that most doctors were using ChatGPT more or less like a Google search. So they were asking for factual rather than generative tasks. Those that gave it more complete information, often by cutting and pasting and that sort of thing, got a lot more out of it. This is, again, an implementation problem. GPT, AI in general, it's helpful, but we have to test how to use it. It needs to be better integrated to get the most out of it. Okay, that's the end of my half. I want to give you just a couple of takeaways. First, we do not have to choose between basic research and developing best practices and developing best practices and research into their application. Both are important. Second, implementation science is a great method to study how to bridge that disturbingly large gap between evidence and practice. So enough about theory and history and the why and the what. I'm turning over to Donna for the how. Go ahead.
All right, thank you, Steve. Steve provided an excellent overview for why implementation science has gained traction as a field. And as he said, I'm going to be focusing on how implementation science can amplify the impact of traditional research efforts and offer a bridge to translate evidence into action. Before launching into that, I want to build on some of Steve's comments about where implementation science methods fit within the context of broader research efforts to help improve health. On the left side of this slide, we have an intervention. This could be a medication or diagnostic tool or clinical service that has emerged from basic science and other research. And we want people to get this intervention because there is evidence, typically through clinical research, that it improves their health status, quality of life, morbidity, and/or mortality. But patient outcomes aren't the only outcomes we care about. To evaluate whether patients are getting the care they need, we often study service outcomes that are upstream of patient outcomes through health services research, quality improvement, and other efforts, where our primary objective is to ensure that patients are getting efficient, safe, timely, patient-centered care. Implementation science is concerned with this yellow box here, the steps that are required for an evidence-based intervention to influence service outcomes and patient outcomes as intended. And interest in this field has grown out of observations that specific frameworks and measures and methods can help maximize the impact of interventions when they are implemented and disseminated in the real world. Specifically, implementation science adds two more boxes to this framework, which was proposed by Enola Proctor over a decade ago: implementation strategies and implementation outcomes. And the goal of understanding these domains is usually twofold. First, as Steve said, like quality improvement, there is a goal of improving process within a specific setting in service of the broader goal of improving patient outcomes. Second, like traditional research, there is a goal of advancing generalizable knowledge, in this case, often about the implementation strategies themselves and their relationships with implementation outcomes. Steve's presentation highlighted how there's a persistent gap between what we know and what we practice. To illustrate how implementation science can help bridge this gap, I'm going to return to the case that Steve shared about a gentleman with heart failure who was not on optimal therapy. This is a great example of where physicians know what to do, but many patients are not benefiting from that knowledge in practice. And using this example, I'm going to walk through how implementation science might be useful. So the first step of this bridge is to define the evidence. Here we delineate the evidence for interventions that improve outcomes for the clinical scenario of interest. Again, the clinical scenario I'm going to walk through in this presentation is heart failure with reduced ejection fractions. It's a great example where we have a strong evidence-based intervention. For patients with heart failure, there are 4 medication classes with robust evidence for health benefits. Specifically, these medications improve heart failure symptoms, reduce heart failure hospitalizations, improve patient-reported quality of life, and reduce risk of mortality. This is one example of many studies that have demonstrated the positive impact of these medications. These are survival curves for patients enrolled in United Healthcare Insurance between 2007 and 2019. They show the 2-year survival rate was 81% for individuals with heart failure who were not on recommended medications, 84% for those receiving at least 1 recommended drug class, and 86% for those who were receiving at least 2 recommended drug classes, translating to a 29 to 37% reduction in mortality. And this is a situation where more is better in that multiple drug classes are better than one. This large systematic review and meta-analysis published in 2022 illustrates lower all-cause mortality when patients are on more than 1 drug class. And as shown at the top, the hazard ratio for all-cause mortality is 0.39 when patients are treated with all 4 drug classes simultaneously. So there's strong evidence for these medications, and based on the strength of the evidence, these medications are central to American Heart Association guidelines for the management of heart failure, as described by the writing committee led by Stanford cardiologist Paul Heidenreich, with contributions from Alex Santu, also from cardiology. However, implementation of these recommended medications has been suboptimal despite strong evidence for their benefits. This figure shows prescription rates in the CHAMP Heart Failure Registry, a database of over 3,000 patients with heart failure with reduced ejection fraction, and illustrates low usage rates for all 4 recommended drug classes. So these medications are not being prescribed as often as recommended. And furthermore, the medications are not being titrated up as recommended. These pie charts show data from the same CHAMP registry and illustrate that among individuals who have a prescription for a recommended medication, a large proportion in red are receiving less than 50% of the target dose. So we've got a well-established evidence-based intervention, these 4 drug classes for heart failure with morbidity and mortality benefits. And there's also evidence of suboptimal implementation. Overall use of these medications is low, and titration of these medications is not occurring as recommended. So we have this established, we've established that there's this gap between what we know and what we practice when it comes to recommended medications for heart failure. The next step of this bridge is to understand the barriers to optimal implementation. And there are many of them. It will come as no surprise that barriers to implementation are multifactorial. So a number of frameworks and approaches have emerged to assess the factors impeding implementation of specific interventions. This is one framework, the Consolidated Framework for Implementation Research, or CFIR, and it distinguishes between barriers that occur external to the health system in what's called the outer setting. These are factors related to the population being served and external policies and incentives. Barriers within the health system or organization, the inner setting, such as structural characteristics and organizational culture and climate. Barriers specific to the intervention, such as intervention complexity and cost. And barriers specific to the implementation process and individuals involved in implementation. This type of framework can be extremely helpful during formative stages of a project to understand specific barriers that need to be addressed, and we'll typically assess barriers like these through qualitative interviews or surveys with various stakeholders. So coming back to the case of untreated and undertreated patients with heart failure, a number of studies have identified barriers to getting patients on appropriate medications at optimal doses. And these barriers exist at multiple levels, at the level of the health system, such as pharmacotherapy policy and pricing and inaccessible specialist care, at the level of the clinician, such as physician knowledge or communication gaps, and at the level of patients, for example, patient preferences against changing therapy. Understanding the factors that impede implementation at these different levels can then inform the next step, because once we're aware of barriers to implementation, there's an opportunity to identify specific implementation strategies that will address those barriers. So that's step 3 in this translational bridge between what we know and what we practice. These implementation strategies are the methods or techniques used to enhance patient access, provider adoption, implementation, or sustainability of an intervention. And there are dozens of implementation strategies that have been designed and shown to facilitate adoption and sustainment of interventions. Some are relatively simple, like supporting clinicians through a decision support tool or clinical reminder, or engaging patients through mass media. Others focus on adapting and tailoring to context to ensure that materials and process fit a given setting. And often a system might utilize a bundle of strategies that target barriers at multiple levels. For example, making changes to infrastructure and financial incentives while also implementing decision support for clinicians and patient education. This is one example of a bundle of implementation strategies that were part of a cluster randomized trial in Western Kenya, where the goal was to improve management of hypertension by strengthening referral networks. And you can see that the bundle includes a couple of peer support interventions together with several informatics tools, including decision support, patient tracking, and referral metrics. So bottom line is that there are many different types of implementation strategies. What they have in common is that they are approaches that are put in place to optimize implementation of the intervention. In order to get a handle on the vast number of implementation strategies, researchers undertook an effort called ERIC, Expert Recommendations for Implementation Change, in which they cataloged and categorized over 70 implementation strategies. This is a very helpful resource for those who are trying to understand the landscape of strategies. And one way it comes in handy is when researchers want to test different implementation strategies to determine which one results in the intervention reaching the most patients or having the greatest impact. Those trials of implementation strategies can be valuable not only because they determine the best mechanism to improve care for patients with a specific clinical condition in a specific setting, but also because they generate knowledge about strategies that might generalize to other clinical challenges and settings. So just an example of this cluster randomized trial aimed to understand the best strategy for giving staff at residential care facilities reminders to sustain a mobility intervention with older adults. In this case, the trial was focusing on both the frequency and the intensity of reminders, and the outcome of interest was the rate at which residents were completing a sit-to-stand mobility activity. The study found that a high-intensity, high-frequency reminder, these were monthly reminders from peers at the facility, was the most effective, much more effective than monthly paper-based reminders and quarterly peer and paper-based reminders. So this is a nice example where they've identified the most effective reminder system for a mobility intervention in this setting for this clinical scenario, but they've also generated valuable evidence about reminders that could potentially be relevant in other contexts. So what do these implementation strategies look like when it comes to heart failure? There's a wide range of strategies that have been tested to optimize heart failure care in general. Some are system-level interventions, such as multidisciplinary virtual care teams and EHR-enabled algorithms that identify high-risk patients. Others focus on patients themselves, for example, by empowering individuals and tracking the status of their conditions in their homes. Still others support clinicians, for example, through algorithmic initiation and titration of medications. I'll share 2 examples of studies that evaluated 2 of these strategies. The first is a study of an EHR-based clinical decision support tool, which is a pretty common implementation strategy to encourage adherence to clinical guidelines. Prompt heart failure was a cluster randomized trial in which clinicians in one arm received alerts where they were shown a patient's current therapies, and they were prompted to use an evidence-based medication order set. And the study found that alert exposure was associated with an over 40% increase in prescription for a recommended drug class, as shown by the comparison between dark blue bars above and light blue bars below. So this is an example of a fairly simple implementation strategy that is low cost and can offer modest benefit in terms of getting more patients on recommended therapy. On the other end of the spectrum, the Implement Heart Failure trial evaluated a more complex and costly strategy. In this study, researchers allocated hospitalized patients with heart failure to usual care or to a virtual care team that provided guidance to improve the patient's medication regimen. So clinicians of patients in the intervention group received suggestions from a remote physician-pharmacist team to encourage optimization of medications. When comparing patient encounters where clinicians received the virtual care team guidance in red to those where clinicians proceeded with usual care in blue, the implementation strategy was associated with a higher rate of intensification of at least one recommended medication, 50% versus 28%, and a higher rate of initiation of a new recommended medication, 44% versus 23%. So a more dramatic effect here with the more costly, more complex implementation strategy. And just as we've seen here for any clinical intervention, there are likely to be a range of implementation strategies that will facilitate adoption. So the question is, how do we choose? Well, in addition to cataloging common implementation strategies, implementation science offers approaches to help map strategies to specific barriers. There are a number of pragmatic tools to aid researchers in identifying the optimal strategies for different situations, including a tool that matches barriers from that comprehensive consolidated framework for implementation research to strategies from the ERIC catalog of implementation strategies that I mentioned. And what this looks like in practice is once we understand barriers to implementation, as has happened in the case of heart failure medications, we can select, test, and evaluate evidence-based implementation strategies. So for example, if at the health system level, a major barrier relates to inaccessible specialist care, the system might put into place dedicated heart failure medication titration clinics. Or clinician knowledge gaps might call for empowerment of nurses and pharmacists, or an EHR reminder to alert clinicians when one of their patients is a good candidate for a medication. And barriers at the patient level might suggest a need for education and engagement efforts that target the population of interest. These mapping exercises can help ensure that the selection of implementation strategies is grounded in data about barriers and is strategic in terms of likelihood of addressing these barriers. And then once the implementation strategies have been selected, the next step is to evaluate outcomes specific to the implementation process. So coming back to this framework, implementation outcomes are the direct effects of actions to implement treatments, practices, and services. These outcomes might be used to evaluate the implementation process or the success of implementation efforts. Depending on the goals of the evaluation, we might be interested in acceptability of an intervention among stakeholders, the appropriateness of that intervention within a given setting, adoption rates or intentions to actively employ an intervention, penetration, this is the integration of an intervention within target sites, the reach of an intervention, which is the proportion and representativeness of the population that receives it, implementation costs, or sustainment after the pilot period has ended. These are all examples of implementation outcomes. And importantly, evaluations of these outcomes can be done together with more traditional evaluations that are looking at health outcomes, utilization, patient experience, quality of care, and cost. In fact, a hybrid study that examines the effectiveness of an intervention together with the implementation process and sustainment potential often offers the most valuable information for future dissemination. So that's a very strong and common design for an implementation science grant. Returning one last time to the scenario of heart failure medications, this is from a systematic review of RCTs that compared implementation strategies aimed at increasing the reach of recommended medications. As shown in blue at the top, interdisciplinary heart failure medication clinics were associated with modest improvements in the proportion of patients taking recommended medications, although some studies here did not achieve statistical significance. But as shown below in yellow, this implementation strategy was associated with a striking improvement in the proportion of patients taking target doses. And the effect of some of the simpler, lower cost implementation strategies in this review, such as outpatient audits, was more subdued. So even though these interdisciplinary clinics are a costly and labor-intensive strategy, given the morbidity and mortality benefits associated with optimal medication dosing, this systematic review concluded that the interdisciplinary medication clinic is likely to be a cost-effective implementation strategy in the long run. Finally, once we've identified implementation strategies that yield desirable outcomes, implementation science studies aim to facilitate scale-up and spread of evidence-based high-impact interventions. There are a number of factors that have been found to be key to successful sustainability of effective interventions. Many of these factors can be assessed during early stages of intervention design and implementation, such as environmental support, funding stability, partnerships, and organizational capacity. And there's growing recognition of the value of preparing for sustainment early in intervention design and implementation trials. So there are various surveys and other tools to help with this. Dissemination of sustainable effective practices is an area where large integrated health systems such as the VA have an advantage. The VA's Quality Enhancement Research Initiative, QUERY, has been in place for over a decade and has made tremendous advances in the science of implementation and dissemination. Guidebooks, national programs such as home telehealth for veterans with heart failure, and dashboards that facilitate auditing, feedback, and population management are all examples of tools that have supported the dissemination of best practices and effective implementation strategies. There's one more important component of this bridge, and it's really a cross-cutting one, because at each of these steps, implementation science offers systematic approaches to advance health equity and reduce disparities. A recent scientific statement from the American Heart Association described how implementation science can help achieve equity in heart failure using a drawbridge analogy. The statement describes how biases and structural determinants are like the cogs that keep the bridge open and result in persistent gaps in care delivery. Implementation strategies are like the cogs that offer a counterforce to help us close that bridge and reduce those disparities in care. And there's a growing sentiment that health equity should be a standard consideration in implementation science studies. One of our colleagues, Jessica Breland, a VA investigator who's affiliated with Stanford Psychiatry, gives a lecture in the course that Steve and I teach and poses a challenge to our students that every implementation study consider the question, how will the intervention, if implemented effectively, explicitly reduce health inequities and promote health equity? So fortunately, there are a number of specific frameworks, adaptations, and outcomes that are emerging that can be very helpful in supporting these efforts. And while I focused our presentation today on applications of implementation science for a cardiovascular condition, I wanted to highlight that implementation science is taking off across a wide range of medical specialties. These are just a couple of recent papers in JAMA Surgery, New England Journal, Lancet, and JAMA Network Open that describe implementation science trials and other research. And a shout out, the paper at the bottom, which focused on advanced care planning in adults receiving dialysis, was accompanied by a commentary written by Manju Tamura in nephrology and Laura Holdsworth, a qualitative researcher in primary care and population health. Along with this rise in publications of implementation science studies, we are seeing growing calls from funding agencies for grants that accelerate and increase the use of discoveries from research and decrease use of ineffective, wasteful, or harmful interventions. Furthermore, many funding announcements for large clinical trials and comparative effectiveness analyses require an implementation core or implementation evaluation, highlighting the potential for those hybrid studies that I mentioned that examine effectiveness and implementation together. We're fortunate to have a growing number of faculty at Stanford who have expertise in implementation science, including Mark McGovern, who started SUNDIR, the Stanford University Network for Dissemination and Implementation Research, Lisa Goldman-Rosas and her team from the Stanford Medicine's Center for Community Engagement, faculty such as Elise Adams, Sarah Singer, and Arden Morris, who apply implementation science in the context of epidemiology, health policy, and surgery, respectively, and others who are applying implementation science in quality improvement efforts. And one of the largest collections of researchers with expertise in this area is the Center for Innovation to Implementation, CI2I, at VA Palo Alto, that I helped lead together with Susan Frayne from Primary Care and Population Health and Dan Blonigan from Psychiatry. Our center investigators, only some of whom are pictured here, focus on the implementation and dissemination of a wide range of clinical services, including primary care, mental health care, surgical and subspecialty care, women's health, geriatrics, palliative care, telemedicine, and caregiving. So for those who are looking for partners with implementation science expertise, please reach out. I'd be happy to help with matchmaking. And another fantastic source of potential collaborators in our very own department is the Evaluation Sciences Unit, or ESU. The ESU, directed by Marcy Winget, is a wonderful group of scientists with extensive experience applying qualitative and quantitative methods to implementation science projects. If you're looking to develop an implementation science core for a grant or existing project, I highly recommend reaching out to Marcy Winget or Steve Asch. So coming back to our takeaways, Steve described how, fortunately, we do not have to choose between research that generates best practices and translational research into their application. Hopefully, our combined presentation has illustrated how implementation science offers some rigorous frameworks and measures and methods to extend the impact of clinical and health services research and quality improvement efforts, and can increase the value of team science. This is a highly collaborative field with opportunities for widespread application, so we hope that you will reach out if you're interested in this topic. And we look forward to your questions and discussion.
Thank you, Drs. Asch and Zulman. That was wonderful. It's kind of, what's the point of doing all this amazing research if it's not getting implemented to our patients in the first place? So it's such an important thing. I'd like to first start with Dr. Chang. I'll turn over to you. Thanks, Dr. Chang.
Wonderful presentation and an incredible summary of why it matters. Thank you so much and congratulations. I'm going to start off the questions. I'm sure there will be more, but it seems like so much of implementation falls down based on sort of human psychological behavioral factors. What's the role of behavioral science and sociology in implementation science? And a related but slightly a separate question is, how can we have patients be more involved in implementation science?
Great question, Song. Thank you very much for those questions. So I think implementation science is essentially a social science. Its roots, its intellectual roots are in sociology. Everett Rogers was a sociologist. So how people are organized and their behavior could not be more important, and is very much taken into account, not just in the theoretical structure of implementation science, but in the how, like how we use the lessons of implementation science. Patients, it's an interesting issue, right? So a lot of this dialogue or two-way street thing that I was talking about comes from community-based participatory research, which is about having patients involved in decision-making, both clinically and in creating a research agenda. I think implementation science has done a reasonably good job at it, but could do a better job at doing so. Most of the time, we think of our community as the delivery system itself, and I think that's insufficient. So with partners like Lisa Golden-Rosas, I really hope that we can do a better job in the future.
Great, thank you. Dr. Weinecker?
Hi, thank you, Errol. Yeah, this was a really wonderful presentation, and it's something that certainly I've struggled with for the longest time, is trying to figure out why, when we have good evidence, we can't implement things that improve patient care. My practice is in the ICU, which is a fairly contained group of people here, and it would seem that we would really be able to easily convince people to follow the evidence and do the right things. And when I think of how long it took us to convert most of our faculty even to doing lung protective ventilation, for example, it was shocking, honestly. So I love all of the examples that you've given of how to try to implement things that we know work. Can you give an example or two of things that you have done here that you have been particularly successful with, and why you think it was successful? Was there some secret sauce in addition to the things that you mentioned?
No secret sauce, Anne, that I know about, but I will give you some examples. So we have been working with SHC on various programs and evaluating their efforts to try and reduce readmissions, to try and improve follow-up after ER visits, to try and look at telemedicine, for instance, which I think, we all know is here to stay, but how to implement it is the hard problem, right? And those have met with some success. Why? It's a bespoke problem, man. Like it's a targeted, tailored thing every time. I can tell you there's some things that are absolutely crucial. You need leadership involvement. This is not one of these things that you need an implementation scientist to tell you, but in general, you need some sort of support. I think you need the stakeholders to believe that the problem is real, and that's often a hard problem, just convincing them that it's really out there. But I think there's a lot that implementation scientists have done to improve it. I often, when asked this question, I deliberately started just with things here at Stanford because I thought that was your question. But often when asked this question out there in the world, I refer to Peter Pronovost as like the paradigm of what we could do in the ICU to reduce healthcare-associated infections with line insertion. That 40% drop saved presumably thousands and thousands of lives, probably more than the development of lots of technologies that cost huge amounts of money. And the NIH has begun to recognize this, so there's a lot more funding now for implementation science, and we can help if there are people who can hear me and who are applying for those kinds of work. So I hope that at least gets to part of your question.
Yeah, thanks, Steve. It's a very cool problem to solve. I mean, to be able to solve it is a very cool thing. So thank you for your both of you for this great talk.
Thanks, Dr. Weinecker. We have now a bunch of questions on the Q&A, so I'd like to get to. I'll start with Sonu Thanedi's question. What incentives are there in healthcare systems to lean in on implementation science? That's a really important one.
Donna, you want to take a crack at that?
Sure. I mean, I think the incentive is the outcomes that we all care about, that by implementing these strategies, we can ultimately improve patient health and well-being and improve hard outcomes like morbidity and mortality. So I think that's the major driving force. But the other, all of the surrounding things, the clinician, wellness, the workforce efficiency, those service outcomes that were kind of that second to last box on the chart are also, the opportunities are to improve those outcomes too. So I think the service outcomes coupled with the hard patient outcomes are really what drive the incentives for clinicians and for health systems to focus on implementation.
Another question here. Thank you for your seminal presentations, Dr. Asch and Dr. Zulman. Your thoughts and perhaps examples on new policies improving implementation science. Clinicians and health scientists can only swim so hard against the current system flow.
Donna, you want to, or you want me to do that one? Okay, no problem. Okay, so yes, I couldn't agree more. The system is not really set up for success, and we do need more kind of more structures that encourage rapid evaluation of new ways of doing things. And that's actually what the ESU is supposed to be about. And I love that we have been able to partner with our academic medical center home to work on those kind of things. And if you look across the country, there are more and more of these kind of evaluation shops within academic medical centers. And I think that is a structure that will incentivize trying to figure out which of the myriad of efforts that people are undertaking to improve things are actually working.
Great. Dr. Liebowitz asks, have you looked at the effect of ubiquitous television advertising on drugs, on implementation science, in comparison to the other interventions you discussed?
Yeah, short answer, no. I mean, direct-to-consumer advertising and just social marketing and in general is a huge problem in healthcare now. I think it kind of parallels this what I consider to be lamentable decline in the value of expertise, and anybody can make a decision about anything. I hope what implementation science can do is it can try and set up valuations that people will believe, right? Like counter that kind of stuff with real evidence. Donna, do you want to add anything, particularly the equity work?
I'll just add that I think historically implementation science was very much focused on the health system and healthcare delivery organizations. But I think there is opportunity to couple the health system focused interventions with more public health types of strategies. And potentially that's going to be the strongest way to influence changes within the health system and to get the consumers engaged and pushing from their end as well. So I think that's a great opportunity for the future.
Great. As we get closer, we're at 8:59, but I have a few good questions here. I might bring them together because there's a little bit of overlap. Dr. Georgie asks, says, great presentation. Thank you. You have aptly identified pharmacotherapy prices as a barrier in adherence to therapy. What can we individual providers do to overcome that? Along with that, Dr. Clever says, given the high level of interest and number of individuals and centers involved at Stanford, how do you all stay coordinated in order to avoid duplication, competition, and gaps? And lastly, if I could add, Dr. Chu just asking about the disincentives that stand in the way of implementation science. Steve, you're unmuted.
Hard to answer all three of those at once. I will, yeah, I'll do my best. The coordination issue is the easy one, so I'll take that one first, which is there's a lot of camaraderie amongst the implementation scientists across Stanford and the VA, and that's great. So we often do kind of talk together about what to do, and I'm really happy that Mark McGovern, for instance, has set up a forum for us to do that. So I'm not saying that it's perfect, but I think we are really trying hard to make sure that that we work together as a group and avoid unnecessary competition. Pharmacy prices, I wish I had the answer to that question. I mean, that's a huge problem. I don't think it's an implementation science problem. I actually think it's a policy problem and a political problem more than anything else. But what implementation science can do is it can try and connect people to the programs, the existing programs that are designed to reduce effective pharmacy costs, meaning to help them pay for their medications. I think I missed the third one.
Just about general disincentives and then general disincentives and then pharmacotherapy prices. What can we do, and just overall, what can we do to be coordinated, essentially?
Yeah, I think I covered it as best I could.
Yeah, that's excellent.
I'm really grateful for the opportunity to, and I know I'm speaking for Donna, to be able to answer your questions.
Yeah, thank you so much. We're just hitting just past 9, and I know people are heading off to clinic now. Dr. Zulman, Dr. Asch, it's great to see you up here. Thanks for being such a great support to the medical grounds community for years in multiple ways, and thanks for all the amazing work you do. Great to have you with us today. Thank you for everybody for staying with us.
you.
Have a great day, everybody. Bye-bye.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.